الله يحييكم. اليوم معنا محاضرة عن البوبوليشن هيلث مانجمنت in عسير، يقدمها لكم الدكتور مشعل سالم العمري، Director of Population Health Management and Population Health Department, Public Health Department in عسير Health Directorate. نرحب فيك يا دكتور مشعل، والله يحييك وتقدر تبدأ المحاضرة.
الله يسلمك. السلام عليكم ورحمة الله وبركاته. Good morning, everyone. It's my pleasure to be here with you today. First, I would like to thank the Health Holding Company and the Transformation Management team for hosting me. I'm Dr.Meshal Alamri, Director of Population Health Management at Aseer Region. I will speak today about the concept and what is meaning of population health management. Then we will speak in the other part about population health management in Aseer Region. First, I would like to start with what determine our health. The determinant of our health, it's distributed to 5 main categories. It's how we behave, contribute 40% of our health, and healthcare system 10%, environmental 5%, genetic 30%, and social 15%. And the main part and the main thing that affect our health is how we behave or behavioral lifestyle, 40%, then the genetic, then the social, and finally the healthcare system. So the question now, where we are spending our money, the health expenditure, the distribution of health expenditure, is it as the percentage of what makes us healthy as a determinant of health? It's not surprising that 88% of health expenses goes to healthcare system, from the system itself, the building, hospitals, and B2C, and just 4% for the behaviors and how we behave. And it is unequal equation. When you invest 4% to get a result of 40% and put 88% in healthcare system and only get you a 10%. The rest of the 3 categories have just 8%. So we don't have a problem with this, spending 88% of our expenditure to the healthcare system itself. The problem is that 88% is not giving us the 10% that we need. It's there is a lot of waste, a lot of misuse of this budget. So the idea of population health management come in with the triple aim. It's called the triple aim of population health management. And the triple aim concentrated in 3 things: that's the health, the care, the cost. And it's meaning that we need to enhance and get the population a better health, or what we call improve the health. The second is the care, which enhancing the care that we are providing to the population, or enhancing the experience that's the population experience when they interact with the system, health system. The third, and that's the challenging thing, is to reduce the cost. So we reduce the waste and to be efficient in matter of money. So it's logic that we want to improve the health, we want to improve the experience, but it is very difficult to reduce the cost in contrast with improving the health. It's very difficult that you want to enhance something and get it better, but you want to reduce the cost. That's the triple aim stand for, and that's what the idea of population health management comes for. So what is the population health management? The population health management, it is a concept, and the main thing, the most important thing about population health management, it's concept. The definition is not that important, because there is a lot of non-consistency in the name itself. Every agency, every country define the population health management according to their situation and how they use it and what is the tool that they are using. Like this definition, it's the study of distribution of health outcomes within a population to help determine the influence, the distribution, the policies, and intervention that affect the determinant. Another definition also related to the data and using the data, which improve population health by data-driven planning and delivery of practice care to achieve maximum impact. So the idea is the same, but with different definition. The third topic, and it's a very important topic, when we introduce the idea of population health, that's the misconception between the public health, population health, and community medicine, or community health and preventive health. There is a lot of interaction between the three part of fields, and it's logic to be so that there is an interrelation, because they work with the same concept, they work with the same purpose, but they work on the different level. And this is the key to differentiate the three main topic or three main fields of medicine. The public health usually work on the higher level, the upper level. We speak about international level, we speak about WHO, and the level that give legislation and policy, and on governmental level. And it's usually dealing with large scale of concern, like and threats, like the pandemic of corona, and that's what they call managing disaster and controlling infectious diseases. Also vaccination programs, also environmental hazards. So they deal with big things that's related to public, and by meaning public, to all population. On the other hand, the community health, it's related to well-defined geographical area, small area like a village, like a small city or towns, and they work on this this place with all of the determinants that affect this place, like social determinants. Usually they work on social determinants and other determinants, and that's the main difference between community and public health. Public health work on higher level, in policy level, in governmental level, with small and big interventions, while community health work on a small community with multiple interventions at the same time. And the population health come in between the two main concept of public health and community health. It's working on the level of health system itself. So it's working like in directorate, in clusters, in sectors. So it's work on the system itself, and it's have main interact or intervention, that's it's work to arrange the integration system. So it's integrate the system, so it's to function better between the system itself, between the hospitals, PHCs, home cares, and other part of the system itself. And it's also interfere with the place that the system interact with the patient on the field. So this is the main difference between the three main topics. The public health work on higher level, the population health work on the middle level or in the health sector itself, and the community health, those who face the patient. So we speak about the aim of the population health. So what is the requirement of population health? What's the population health need to function? As any other department, the population health management need resources and financial resources, human resources, infrastructure, and so on. But some requirement is special for the population health management. First is the people, not the human resources, the people. And we speak about people in two type of peoples. The people from the population, because we need to engage the population in taking the decision that will affect them. Also, we need to take a patient from patient groups, so they contribute to decision that affect them. Another type of people is the human resources, who must do the work. We need the basis for the population health management, or the main function of population health management will be on public health, preventive medicine, community medicine. And we need also more specialized personnel like biostatistician, data analyst, IT specialist, epidemiologist. And also we need those who work on community, they interact with the patient like nurses and GP and family physician. The other things that population health management need, it's the data, and it's one of the main component and most important component to the structure of population health management, because without the data you cannot take any action or intervention or a study, or you cannot take any result. So we need a data, and we speak about data here, a big data that's related to millions of population. After that, we need intelligence system and IT that function well to accommodate this data, to analyze it, and to give us a real-time insight to the situation and give us the KPIs that we are needing. The last thing that we need is the system itself. The population health management cannot work by itself. It's work on the level of the system, of the health system. So it's need a working system to work on it and to enhance it, increase the productivity, and reduce the cost. This is what about the population health management. Now, what about how the population health management going to work? The health holding company and the Council of Health Assurance, they have a meeting, and with the help of a consultant and specialist in the field, and they draw the framework of population health management for Saudi, and it's as a guidance for us to work. It start with identifying the population, and without identifying the population that we are working with, we cannot manage our population, we cannot get any result, and we cannot take any decisions. Then we'll start with the cycle of the population health management framework. It starts with population health need assessment, so we can have our intervention, then we prioritize our intervention, then we implement the interventions, and finally evaluate the impact of the intervention. First, identifying the population, it goes in 5 or 4 steps. Start with the registrations and enrollment at registration stage. And this registration, it is from its name, it's registration. We need to register all of the population. And the registration with the minimum data sets, it's around 30 information that's need for every individual of population. This task will be done by the Council of Health Insurance, and then the other step on this it's enrollment at registration stage. And we meaning by enrollment that we enroll the population that we registered to a social health insurance coverage. So because we have a lot of eligibility population. We have Saudis that work in governmental and Saudis who work in non-governmental sectors. We have non-Saudis working for governmental, non-Saudi working for non-governmental, and non-Saudis working for other Saudis. So every group have different eligibility for the insurance. So the work of the Council Health Assurance, they will enroll every population to the right health insurance coverage. Then the second step, it will be assignment. And by assignment, it will happen by the council. They will assign the population to the clusters. And we have here in Aseer 1.9 million of population. They will all assign to the cluster, and we are accountable and responsible for their health. And this is the most important of identifying the population is accountability. So the cluster is account for their health, not their treatment, for their health. And it is very important thing, because it's not just you manage the patient, you need to keep him well, so that you are accountable for their health and responsible for their health. So this is the step that the council will account or enroll the patient or population to the clusters. The steps that after that is attribution. And attribution, it is also enrollment of the population to a group of PHC, either zones or a group of PHC, and also those PHC will be responsible for this group of population. Then the last step, the PHC itself will enroll the population they are responsible for to a pathways. So the population will enroll in the pathway they suits their situation. If he is diabetic, he will go to the diabetic pathway. If he is hypertension, will go to hypertension pathway. So it is the last step of the registration or identifying the population. After identifying a population, and it's a long process, we will start the process of the cycle process and start with population health need assessment. And population health need assessment, it is very important steps because it will give us the priorities where we should interfere, and it's give us the priorities for resources distribution. And it is a method for reviewing the health status, determinant, and demand and supply of the healthcare service for defined population. And one of the most important about the population health need assessment, it's that it will give us the understand of the health needs and the health supply and health demand. So we can manage to distribute our resources and our efforts and where the intervention should be gone. There is a lot of different type of health need assessment, and it's have the same approach of starting with setting aim, define the population and define the problem itself, describe the current service, summarize the evidence from literatures, and summarize the finding that you get from stakeholders and patients and users of the service, then summarizing cost-effective solution and resources, and finally you put a recommendation. After you put a recommendation, you must put with it the indicators that you need to evaluate later on. We have different type of population health need assessment. We start with the community health need assessment, which from its name, it is on local area in a small community. It's have a mixed method of stakeholder meeting, surveys, focus groups, and statistical data analysis. The other type is opportunistic health need assessment. It is opportunistic, so we are targeting subgroups. The third one is comprehensive health need assessment. It is a detailed survey that's administered individually at local level by surveyors, and it's involved a broader data collection. Also, in population health management, we need to stratify the population. So the risk stratification, it is the process of separating member population into different risk groups. There is a different type of stratification. The second step is prioritizing of intervention, and the third step is implementing of intervention. So we're supposed to get we expect to get from the population health need assessment and intervention. So what to do with this intervention? We have to prioritize it so we can use the best intervention at the best time in the best place. How to prioritize intervention, it is a complex and wide things, but you have to take in account four main things: the impactability of the intervention you are trying to enforce or trying to apply, the impactability or the impact for two things: the severity and the size of the impact, either for the intervention or for the phenomena that you are trying to solve. The second is changeability, and we mean by changeability, it is the realistic chance of achieving change. What is the probability that the change that will happen, depending on your calculation or estimation? Then the acceptance of the intervention, the acceptance of the intervention on the level of population itself, those who will affected by the intervention, and the acceptance to the stakeholders, the acceptance to healthcare workers, and the acceptance to the leaders. The third is the feasibility, which resource implication of solution are feasible. You cannot apply an intervention that you don't have resources for it. After you apply this 4 criteria and you prioritize which intervention you need to start with, you implement the intervention. And after implementation, you need to go to the 4th step, which evaluates of impact according to the KPI that you state in the first step of population health need assessment. Also, the evaluation of impact and improvement of performance management is a comprehensive monitoring cycle. So it is a cycle that starts with feasibility assessment of health intervention and KPIs definition and negotiation between provider, health cluster, and national bodies. So it is a cycle. Once you are in this stage, you will start another cycle for the population health management framework. You can have multiple cycles at the same time with a different level. I think we can stop here for recap and question. About the recap, we start by speaking about the population health need, population health management, the concept of it, and the difference between it and between public health. Also, we speak about the triple aim and the requirements that we are need for population health management. We also take a brief about the population health need assessment and the framework for the population health management. عيد.
حياك الله يا دكتور، شكرا لك في المحاضرة الأولى. شكرا لك يا دكتور.
العفو.
ونشوف إذا في أسئلة من الحضور في الجانب الأول من المحاضرة.
السلام عليكم.
السلام ورحمة الله وبركاته.
يعطيك العافية دكتور مشعل على المحاضرة الجميلة والملخص الممتع اللي شفناه في المحاضرة. تساؤل دكتور مشعل الله يبارك فيك، هل في بلان معين في الكلاستر عندنا في المنطقة الجنوبية بخصوص البوبيوليشن هيلث؟ يعني هل نحن ماشيين في خطوات معينة من الخطوات اللي ذكرت سابقا؟ وإذا كنا ماشيين مثلا في الخطوات هذه في أي مرحلة نحن الآن؟ يعطيك العافية دكتور مشعل، شكرا لك.
دكتور ترى الصوت راح تو رجع.
أيوة دكتور مشعل تسمعني؟
إيه أسمعك الحين.
أقول دكتور بالنسبة للخطوات اللي ذكرتها في موضوع البوبيوليشن هيلث مانجمنت، هل في بلان معين في الكلاستر الجنوبي حاليا؟ وإذا كان فيه يعني ماشيين على البلان هذا في أي مرحلة إحنا الآن من هذه الخطوات اللي ذكرتها دكتور مشعل؟ يعطيك العافية.
حياك الله يا أبو سعود. بالنسبة أسير، احنا لازلنا في النقطة الأولى identifying population. احنا بدينا تقريبا لنا سنة الآن ولازلنا في المرحلة الأولى. أول شيء بدينا في أول 3 شهور في تكوين الفريق والانفراستراكشر والتدريب والأشياء اللي لها علاقة بهذا الشيء. ثم بدينا في 6 شهور اللي بعدها اللي احنا فيها الحين تقريبا احنا على نهايتها في identifying the population. فممكن خذينا خطوات كثيرة في health profile، سوينا 2 health profile طلبتها الشركة، وأيضا الgovernance، التريننج، البيلدينج تيم، هذه كل الأشياء خلصنا منها. بدينا في identifying population في 3 أشياء: registration والzoning والcatchment area. بالنسبة للخطة لا زال صراحة الخطة تغيرت مرتين، والظاهر أيضا في كلام أنها بتتغير بالنسبة للصحة السكانية، لأنه الفكرة في أنه الصحة السكانية في جميع الكلاسترات تمشي على نفس المستوى، بما أنه عادة هي خطواتها وأفكارها ونتائجها تكون على المدى البعيد 3 إلى 5 سنوات كأهداف متوسطة، وما بعد 5 سنوات أهداف بعيدة. فما كان في استعجال من واحدة الكلاسترات مثلا سبقت أو شيء، لازلنا كلنا تقريبا في نفس المستوى. في الخطة واضحة الجميع، واحدة لجميع الكلاسترات وبنمشي عليها إن شاء الله. صح في بعض الكلاسترات تقدمت في بعض الأشياء، لكنه الكل على نفس الخطة بنشتغل عليها. أيضا يؤخذ في الحسبان الدكتور نايف أنه لازلنا حنا في عسير ما قد تشكل الكلاستر، احنا ننتظر كثير من الخطوات انها تتم اذا تشكل الكلاستر.
يعطيك العافيه دكتور مشعل، شكرا لك.
شكرا دكتور مشعل. الاخت ابرار من السنترال بزنس يونت. الاخت ابرار عندك سؤال؟
السلام عليكم.
وعليكم السلام، حياك الله.
السلام ورحمه الله وبركاته.
دكتور طارق، منسق برنامج التحصيل منطقة العسير، الله يحييكم.
حياك الله.
حياك الله دكتور طارق.
دكتور مشعل، إضافة لاستفسارات دكتور نايف في موضوع الكلاستر، اللي يعني حسب أول حاجة شكرا على المحاضرة الجميلة والتشريح الرائع. في موضوع الكلاستر أو تقسيم المنطقة وتقسيم منطقة العسير، العائق الوحيد الأكبر واللي واجهنا خلال السنين الماضية دي كلها هو الحصر السكاني اللي بيعتمد عليه كل التوزيع، ولا توزيع على كلاستر، خصوصا بعد دمج كثير من المراكز الصحيه وتكفيل كثير من المراكز الصحيه. والحصر السكاني فشلنا فيه على مدى السنين الماضيه دي كلها، لانه بنعتمد عليه في اشياء كثيره ليست بس في تحديد الهاي ريسك وايدنتيفيكيشن اوف ريسك جروب ولا كده، وانما في التارجتس اللي مطلوب من كل منطقه لكل فئه لها شيء. فما هي الحلول اللي متاحه او المخطوطه الان لمنطقه العسير لمواجهه هذا الشخص العمل يعني؟
حياك الله دكتور طارق. طيب ممكن نناقشه بعد الجزء الخاص بالعسير، لانه ممكن نجيب على السؤال في نفس الجزء الخاص بالاشياء اللي تمت في منطقه عسير، لانه فيه جزء خاص بالكاتشمنت اريا وجزء خاص بالريجستريشن وايضا جزء خاص بالزونينج. بس تنتظر معنا لنهايه المحاضره دكتور. الصوت رايح يا دكتور طارق.
ابشر. اوكي، ايوه اسمعك جيدا، خلاص اوكي، اي سمعتك، تسمعني كده؟
شكرا لك. ايوه نسمعك الحين يا دكتور.
دكتور مشعل، فيه سؤال في الشات. يقول from your perspective during the implementation phase, what do you mean you can't do intervention with no resources? From where you will get these resources?
أنا بس أتأكد، هل قلت أنا إنه ما نقدر نسوي intervention؟ I said we cannot do intervention without the data itself. I mean on this slide, the identifying of population. We cannot start our intervention without identifying the population, because you cannot judge or take any action or take any data without knowing your population. We need to first know our population, then go to the population health need assessment. Yes, we need the resources of intelligence. We need data also the most important resources to us, and we need skilled people with qualification in some subspecialties like data analysis and biostatistician and epidemiologist, IT specialist. I don't know if this answered the question or not.
شكرا دكتور مشعل. ممكن نبدأ في الجزء الثاني من المحاضرة، إذا في أسئلة أخرى نأخذها في نهاية السيشن.
Okay. About the second part of the lecture, it's about what's happening in Aseer region as for population health management. As I said to Dr. Naif, the first 3 months we start around in January of this year. We start by building the team and the infrastructure and doing our governance, internal governance, training and capacity, and increase the capability of the team. And we do multiple health profiles, still not perfect one, but we start to do it. In the 6 months later, we start, the last 6 months, we start in identifying the population. And identifying the population, it's concentrate in 3 things. In registration, as we said before, we start to register the patient to or population to our electronic health records. We rely on the Wahed, since it is the system that is working here in Aseer region, and it was around 500,000 in the first of the year, the registration. It's now reaching around 600,000. There was some difficulties and a lot of initiatives to motivate this work. I think the TBC team with Dr. Sahar Al-Qadi have a lot of achievement in these topics, and we saw the numbers going up since the program started with her. And we hope we get a lot of, there is some targets from the council, the Health Insurance Council, that we need to register 25% of population, then 50%, then 75% of population. So our population is 1.97 million of population. We start on the beginning. We're still in the beginning, but we hope to achieve it. And I don't know, I can't put a timeline, but it's by years. The other thing is the zoning defining and approved. We managed to finish the zoning. This task was given to us from the central team of Health Holding Company, and we work on it around 2 months, and we success to finish it in time. We're still waiting for the approval from the Health Holding Company for this proposal. We use some criteria for this distribution of zones. It's according to proximity, accessibility of the population, the role in the cities, and the resources and the capacity and capability of these zones. We divide the area for 6 zones and or 5 zones. The naming is not important, but Al-Hijaz Road, starting from Bal-Ahmer and Bal-Asmer, Tanuma and Namas, then Tahama zone leading by Mhail, then the central zone or Abha zone, and it's just Abha sector, then the east zone with Khamis Mshet, Ahdur Feda, and the 2 other zones, Al-Madha and Tarib. Then the south zone, which consists of Salat Abida and I think the south, sorry for this, the south zone of Al-Haraja, Salat Abida, and Dhahran al-Junub, and Al-Farsha. The east consists of Khamis Mshet, Ahdur Feda, Wadi bin Hashbal, and Al-Madha. Every zone have a leading city that have the power and have the resources to lead it. And we consult a lot of those stakeholders and a lot of experience in the field, and we get initial drafts. We propose the initial draft to the leaders on the RHD, and we get our final draft. This is related to the zoning. We don't know if there is any administrative decision will take on, depend on the zoning, but it's at least our zoning for accountability of patient. The last thing about the cluster catchment area, and we start setting a plan and also simulation phase. We use the Google Earth Pro to define the population, the cluster catchment area, and we speak here about the cluster geographically. the catchment area geographically, not by population, because later on the registration of population, it's IT work and it must be done by the other company like Ilm company, Wahed, or any other systems. So we start to use the Google Earth Pro, and we managed to finish two sectors out of 19. We cover around 2,500 of kilometer of area. It's just 10% of the area of Aseer region. We still have long to finish. I think it will take 2 more months, in total 3 months to finish it. This approach is, we think it's very successful since it is electronic. We can update it. As Dr. Tariq once asked me about closing and opening a new BHC, we can just change the catchment area easily according to the new distribution of catchment area. Also, it can be shared electronically. The two sectors we finish with, Ahderfed and Al-Gahma, we share with them the file itself. Also, it can be upgraded to be a health map. We know the health map involved the places of food, the places of gathering, the places of collecting water, and so on. So it can be added to the map itself. Also, it is safe and easy to manage and easy to store it. We think it's a big project, but we can manage it, inshallah, into a month or around it. And that's what's going on in Aseer region. As I said to Dr. Tariq about the population catchment area, this work electronically, so we can share it with Ilm or any other company that can divide the place or define the place of the population according to their national address. So if they define the place according to national address, we can easily identify which BHC responsible for this population. I think we finish here. We open for questions.
شكرا دكتور مشعل، الله يعطيك